Good morning, everyone. Thank you for joining the Straumann webinar today. I am Eliza Schultz, Senior Director, Product Management at Straumann North America. This is the third and the last of the webinar series presented by Dr. Edgar Elshar. We received many questions in the first two sessions, and Dr. Elshar did a fabulous job answering as many as time allowed, and he responded individually to those whose questions could not be addressed due to the time limit of the webinar. So I kindly ask that the audience type in your questions in the questions field throughout the session, and I will moderate the Q&A session at the end of the webinar with Dr. Elshar. Also, please register at skill.straumann.com for your CE credits, which will be available within 24 hours via an email. It is my honor today to introduce to you Dr. Edgar Elshar, our speaker today, who will present complications in implant dentistry. Dr. Elshar completed his doctorate of dental surgery, his postgraduate education in advanced periodontics and dental implants, and received a master in oral biology from New York University. He is a diplomate of the American Board of Periodontology and Implant Dentistry. Dr. Elshar is a member and fellow of Implant Team of Implantology and serves on Education Committee and member of American Academy of Periodontology and Academy of Osseointegration. He is currently a clinical associate professor at the Department of Periodontics and Implant Dentistry and the director of the Advanced Education Program in Periodontics at New York University College of Dentistry. Former director and founder of Advanced Education Program in Periodontics at Lutheran Medical Center. He has a thriving private practice in New York City that specializes in dental implants and periodontal disease. Without further ado, I hand it over to Dr. Elshar.
Thank you, Eliza, and good morning, everybody. And some people are from overseas. Good evening. Thank you for organizing this series of webinars. This is my last, as she said, of the three. I really enjoyed them, and I enjoyed the questions. So please don't hesitate about the question. I answered almost all of them, except two of them. I couldn't decipher them correctly. So if they want, they can resend them again, and I'm more than happy to comply with the answers. So I'm going to talk to you today about complications in implant dentistry, a subject that I have been immersed in since I started my career. I graduated in 1997, and my first position was at NYU continuing education, and my job was to clean peri-implantitis. And that's how I got my first shock and awe, as we call it in the States, with peri-implantitis, and that led to complications, and that's how my practice been based. So having said that, I like to start this presentation always with with the question. What is the long term of a dental implant? Since we're going to talk about complications, the good thing is let's start with what is the long term of dental implant? Because there is the short and the long term, and we are in the business of the long term, not the short term. So let me walk you through a case that was one of my first in my private practice. It was a relative that she had very short distance in the posterior, as you can see. And I want you to also put your mind of November of 1999, not 2020. So it's a huge difference in time and the technology. So everybody told her that there was very short, they couldn't put implants. As you can see, this is the mandibular canal on both sides. So it was very limited. And at that time, short implants in the mandibular posterior was not something that we looked for. And this is to show you also how old it is, because the implant at that time was so old, and it's the dates on it on the bottom. So we plan the implants. This is a free hand, and when you open it, you can also appreciate the mental nerve, and that again gives you in perspective the difficulty of that case. So, and if you notice, I placed the implant supracrestal. That didn't go all the way deep because of the fear of making the mandibular canal. And as you know, as a family, that's when problems happen. So let me walk you through from when it was restored in March 2000 and 19 years and 8 months follow-up. So if we look and compare the top and the bottom, you can see that there has been an increase in height. Now, why? We don't know. I don't have an answer for you. Nobody will have an answer for you. And when we look at the clinical part, and you can see there is a fellow from Lithuania, he talked about the thickness of the soft tissue, that this will implement or can affect the long term of the implant and the crestal bone loss. But if you look at this case, she has a very thin soft tissue. Again, why? We don't know. And that's what I start with my chiasms. I call it biology always win. So again, it's speculation. We have to look at the biology and why in every case it worked and it didn't work. So having said that, what is the long term, again, in the studies of the implant? And if we look at this beautiful study from Sweden, and you can see that on a survival rate of dental implants from 9 to 14 years, it is 95.7. Now, keep in mind, when you look at the publication, it is in 2006. That means you had some turned surfaces, not all roughened surfaces, because 14 years, that brings you back in the 90s. If we look at the most comprehensive one is done by Dirks. And you know, in Sweden, it's a social system and everything is reported into the government, centralized. And he was able, with his team, to look at all the charts of the patients. And this is why it's so important, because look at the numbers. You are talking about over 2,000 patients, and you are looking at over 11,000 implants. And that's why it is so substantial, this study. And it's done by 800 clinicians all across. So in that, you have 7.6 out of the 2,765 that lost at least one implant. So implant, it is a successful therapy. The question is, how many patients do need? And we look at it even with the advent of prevention, cleansability, and all of these things, definitely not throwing what we're going now. But if we look at in general, you can see that based on the National Institute of Dental and Craniofacial Research in the United States, patients between 35 and 45 will have lost at least one tooth. And patients over 45 would have lost a few teeth, even in today's dentistry. So which means it's going to have a lot of people that needs implants. If we look also on the global population, if you look at the growth of the population 2050, based on the UN Department of Economics and Social Affairs, you can see that there is going to be a huge increase in the population. And that increase, if you look at the Western world, or at least the United States, it is going to be from 65 and older. So that means people like me in their early 50 or just turned 50, that means we're going to live longer, hopefully, and then we're going to have more to do with implants. And if we have an implant at that age, because that's what they said with 45, that means they're going to live with us for long term. And so how are we going to deal with them? How are we going to manage them at this long term? So if we look also the demand, and if you look at 2016, there was $3.77 billion spent on implant dentistry globally. In 2019, you can see this number is increasing. And on the top of it, you can see that blue, this is a range of the ceramics. They're going to be with us, the zirconia implants, but doesn't mean they're going to replace the titanium, but they're going to be present and they're going to be a huge demand. And depending on the area where you're living, for instance, if you are in California, you're going to have a higher demand versus that you are in New York, and on and on and on. The question is this trend? Yes, definitely we have a problem now in 2020, but this is going to be a bump in the road, and then we're going to go back, and you're going to see that trend keep going up, and the demand's going to only go up. So having covered all of that, let's see what is happening in today's dentistry. This is my first encounter of peri-implantitis. And now, if you've been in the 90s, the biggest thing was the hydroxyapatite. That was a big jump between turned surfaces, we had, or the polished surfaces, we had the hydroxyapatite, and we started having this problem. And it started actually in California. They had a huge rate, success rate, and then all of a sudden, within 5 years, this has started to explode. And this is when I started dealing with peri-implantitis. Now you have to put yourself in my shoes. 1997, I just came out of the program, and I was only trained on polished surfaces. So I've never seen hydroxyapatite, and there was no protocol on how to treat them. And then you're going to see down the line in the lecture a publication that I just got that is justified my protocol that I've done since 1997. Or this case, I love this lady. This is Marie-Therese, showed up in our clinic, and she had this. And it's really, every time I look at this picture, I wonder, what were they smoking when they placed that implant? It's really extraordinary amount of things that you see in going around. Or this patient that showed up in November 2013. It is true story. It came on Wednesday evening before Thanksgiving, and she had swelling in the floor of the mouth. So when I took a scan, if you look at the scan, there was a breach in the mandibular border, the bottom border. You can see there's a fracture into the mandibular border, and that led to a sublingual infection, and definitely I ended up sending her to the hospital emergency. But on Monday, when I came back, I asked that dentist that been treating her, would you please send me the last X-rays? And if you look at the last X-rays, you can see that the border was still intact in January of 2013. So 6 months passed, and this is when you start seeing, or even more than 6 months, you can start seeing the breakdown. So things can be prevented, and also you can see the amount of buildup that is taking place. Or this case that I did myself, I placed the implant. Everything was great, never seen the patient. And then they sent it 2 days before my birthday, which is 27th of January. I got this beautiful gift. And when you look at it clinically, you can see the swelling, the pus, all the symptoms of an inflammation and an infection. When you look at it clinically, this is what I call a human mutilation. Now we have a U shape, which is exactly what we talked about in the last seminar about bone regeneration and those kind of difficult defects. Or this wonderful young lady, she's an architect from Australia. She's 24 years old, and she presented to United States to work in New York. And she had the unfortunate luck to lose number 9, and she had it replaced. And this is the result of the replacement. When you look at it carefully, you can see it's a very thin biotype. And I urge you all to read the last journal, the issue of Journal of Periodontology, March of 2020. And this will define for you the importance of the phenotype around implants, as well as it is on natural teeth. And if you look at it from sideways, you can see that the implant is tilted more buccal with a very thin biotype, thin buccal plate at first. But when you look at the scan, you can see there is some bone here, but nevertheless is the positioning of the implant. So the placement of the implant, again, goes back to what I always say, set your goal and walk your way back, and that's why it's so important. And to show you this case, this is also another fascinating thing, and we know that when somebody is growing, we don't replace the CDS teeth until their growth is finished. That's what everybody think that no, but look what happened with this young fellow. In 2014, he had 2 implants placed on him. So in 2017, the orthodontist takes an X-ray and says, well, look what happened. So if you look at it and go back and come down, it's the growth. So the teeth have moved forward to the implant, and not only that, look amount of bone that grew over those implants. So the parents went back to the dentist, and the dentist said, oh, let's remove those implants. So luckily, his uncle was a resident at NYU, so he brought him to me in my private practice, and I took a scan and look at it. Look where is the mandibular canal. Look at what amount of bone that needs to be destroyed, and the risk for this young fellow, who's a lovely young fellow. Now he's 18, and you can see he could have had a paresthesia. And this is the other side, and you can see the same thing. It's literally the mandibular arch grew up, developed to a point that the nerve is wrapped around the implant. And these are things that we are seeing. Unfortunately, I'm not bragging about that we are doing these things, but this is sad. This can be prevented, and that's what you're going to see. That most of the time, all of these can be prevented. So And the problem is, I like to share this picture with my children. They're growing now; they're much older. But this is what they used to do for me for Halloween. They put teeth and they send it to me, and that's exactly. I cannot see a better picture to emphasize on the fact that we do anything wrong, we can lead to a big disasters. So, what is written in the literature about complications? Well, let's start with Lang in 2004, and you can see he defined two cases: immediate and delayed. In the immediate, you had an aesthetic failure, surgical implementation, and pretreatment planning. In delayed, you can see it is peri-implantitis, prosthetic failures, implant fracture, and implant loss. Now, this is getting lower and lower, the implant fracture, because of we used to get it more with the external hacks. It's much lesser with the internal hacks. But you can see the peri-implantitis, and now it is defined, it is on a huge problem that we have. When we look at the ITI, it's published in Quintessence, you can see that they find the complications factors based on biological, technical, processing, aesthetic, and patients. All of these things fall almost always around. Back in early 2000, I was asked to give a lecture about the 10 common mistakes, and I wrote them down, and you can see them. It's so true, and they can combine everything together. The pre-surgical treatment planning, the distance between implant and natural teeth, distance between implant themselves, the papilla preservation, the flap management, the site preservation, ridge augmentation, sequencing of a case, like for instance, the young fellow, soft tissue management in second stage, immediate implant placement, that can be also a problem. And lastly, the diagnosis of peri-implantitis and the treatment of it. So this is things that I have grown over the years living through, and you can see I'm going to share my experience with you over multiple cases on these things. So let's start with a case where we had an implant, and you can see how old is that implant place. And now we have a failure of a tooth next to it, which makes it also a complication. But the biggest complication here that we have also not only a fracture of the tooth, but also a periodontal problem that's taking place between number 9 and number 10. Now, why this is a complication? Because it's an anterior and placing two implants next to each other. And thirdly, we have a problem with number 10. Now, when you look at it clinically, you know, the tooth basically exfoliated, you can see that the mistakes in that case. First of all, the mistake is aesthetic. You can see the crown on number 8 is so narrow at the neck. The implant is placed a little bit more buccal, but he doesn't care much, and there is a lack of soft tissue. When we come to here, now we have a recession on this tooth, and we have loss of this interproximal attachment, which this jumps us up into the diagnosis of periodontitis in the stage 3, because we have lost over 5 millimeter in the interproximal, not only on the buccal. Now, when we look at it from an occlusal view, you can see the amount of discrepancy in the flap. And you can see also that this implant was placed more buccal, it was cemented. So now we have a cocktail of problems. How can you figure out this? And you have a patient that he doesn't care much about aesthetic, which is good and bad in the same time. So now, if we look at it clinically, and that becomes a little bit more important, especially for me as a periodontist, I see this. So what should I do? Should I extract number 10? And now the patient is already lost one tooth, and he's not somebody who loves to come to dentist. Or should I try to preserve it as a periodontist? So let me share with you what I did in that case. So I always thought, as we started, we're talking from the first webinar to the second webinar to the third webinar, it is about the digital planning. I always do the same thing, intraoral scanning, compiling the two together. And now I look at it on the co-diagnostic. And when we look at it in the co-diagnostic, now you can appreciate the amount of attachment loss, we call it. And this is the bone and the soft tissue that took place around that tooth. And not only that, number 10 is rotated, so that makes it even harder. Now, when you look at it clinically, you can see the discrepancy of the soft tissue. Yeah? And that means the ridge is the amount of width and height that we have in this case. Again, we can put them both in perspective. So now we know that we are dealing with vertical and horizontal augmentation. So I planning of the implant, I prepare where I want to have it and how I want to have it. And then I went ahead with the surgery. We talked about it last week when we talked about the ridge augmentation. I defined my flap. Here, because I am dealing with an implant, I went submarginal on that. And you can see papilla preservation intrasulcular, and I open, and lingually I go to the line angle, and I can create a submarginal on the lingual. Full thickness, again, exposing up to the nasopalatine. And now I started by cavitroning the root. I placed my biologic, it's an endogain here, and I prepared my implant placement, and I used the ring that we talked about last week. So this is a ring allograft that created a kind of a grafting around the implant. And this is the challenge here. Can I grow bone and make this leveled? And that's what we're gonna see with that case. So I put the allograft, I layered the cortical on top, exactly what we talked about last time. And I put the flex membrane. And then I stretch the flap. This is a fibrotic tissue, so I don't make vertical incisions and I don't cut into the periosteum. So if I have a fibrotic tissue, then I remove the inner side of the flap, which is where the housing of that fibrosis, and then I mobilize the flap all coronally. And this is a post-op, immediately post-op X-ray, just to illustrate for you the initial placement. And this is a follow-up up to 8 months. So we started with a lot of loss of attachment here to where we achieved here a good attachment. So now on a radiograph, we call it a repair. We don't know the amount of buildup of bone unless we do histology or we see it clinically. So now comes the time of the surgery. And these are questions that they've been asked. How would you manage the soft tissue after you stretch it all the way down? Well, I answered it last time and I said, I will talk to you more. So I will show you my flap. So I mobilize everything down here. So that means the flap is here. So now what I do is I do a U shape and I mobilize everything apical and coronal. Now, watch what I'm saying with that. Now, secondly, here, I did splint that tooth. It was very hard to splint it from the lingual because there was no interocclusal spacing because of the rotation. He doesn't care. He's a very easy guy. I mean, this is a lucky guy to be able to do all of these things. We splinted like that, not a very aesthetically appealing one. But now let's look at the bone. Look at the amount of bone that we have achieved. Look, this is bone that has grown under the holding cap. Now, again, I'm a periodontist. The first thing I do, I take my perio probe and I sound the bone. This is bone. There is no invagination of soft tissue. Now I dig out the implant basically, and then we go ahead and we mobilize the flap to position it where it should be. So this is the band of keratinized tissue, and everybody agrees on 2 millimeter. And now I can position it wherever I want. I want to have it here or I want it here. And that's how I can manage it. And that's why it's so important to start suturing here, not to go all the way back. And sure enough, I suture one here, one there, so I stabilize, and then I do. These not interrupted suture, these are horizontal matrices. Now, I have discussed with the patient the amount of soft tissue here. He is not willing to do anything more than that. I'm surprised that he went through the whole treatment. And then this is to show you the occlusal view of the repositioning of that flap. This is kind of an apical, but also apical coronal. So I managed my own level at the same time of the management. And now we go ahead and we look at the radiograph, and you can see I really had to dig out a bone, and the prosthodontist had a hard time even to take the impression. But this is the temporization that this patient been with, and he has been extremely happy. And this is really a great work. I'm surrounded with wonderful people, and prosthodontist Dr. Shermi Farahani, and a wonderful lab, Romano Giacomo, that does beautiful things. This is still on the temporization. He was just supposed to receive the final, but nevertheless, he's not somebody that wants to have treatment. He's my lawyer, actually, and he's very difficult to bring back. And you can see his plaque control. I kept it on purpose because that's part of communicating properly, that this is very important. And we're going to see later on, before rushing into things, we have to monitor those patients. Are they capable of maintaining themselves? And that's a very big question that we have. And that's what we're going to see, the risk of peri-implantitis. So moving along, this is another case, this lovely lady that we started with. And this is the management of this implant. Now, the jury is out there. I mean, at first I said, let's remove that implant, let it heal and build it up on all of that. There was out of the question, the gentleman that bought that practice, and he inherited that case, and he said, can you do something? I said, okay, we'll try. So let's see how we can do it with soft tissue. So the first thing I did, I said, bury the implant. So we removed the temporization and we buried it. And that's just to give you a brief about it. So it's very hard because that implant is literally coming back. Now, if you want to put soft tissue with a connective tissue, and you're going to run a high risk because now you have removed a tissue that you've cut off the blood supply and you put it over and you snug it under. So you need to have a blood supply. The blood supply, where is it going to come from? You have metal here that is going to impede on the survivability of that implant. Secondly, you have a vertical defect that you have to deal with. So if you look at it also from an occlusal view, you can see where the implant, look at the deficiency on the soft tissue, and also you can appreciate the height and the width problem. So this is what I urge you to read this chapter. I have 2 chapters on that book, one on periimplantitis and one on the soft tissue management around the implant. And again, I go for the roll technique. Now, the roll technique, it's not my own technique, but I have modified it. What do I mean by that? Well, the original one that was came from UPenn, from Dr. Abrams, he did 2 vertical incisions and rolled it underneath. And then picked up later on Implant by Dennis Tarnow and Scharf. And they did it, but when you put it with vertical incision and you bulk up, you end up with this, what I call this rolled over that implant. And so that can be a problem. So now what I did is I have placed I rolled the soft tissue under, and I tucked it underneath it, and I control the depth of that soft tissue. That's what is so important. I was able to control the depth of that soft tissue. So, and this is how I can control all of these things. So I passed it under, and I tucked it under, but this is why I can control. I have no vertical. I created a pouch and I passed it underneath. And then I put back the temporary and we trimmed it. Now I can tell you the biggest problem we had in that case, that they temporized it with an Emax. Don't ask me why. That was the biggest surprise I had. And cutting off an Emax, that was not fun to do. Sorry, zirconia. So this is to let the soft tissue heal. It's very important to create a space under, and I talked about it last week, because if you put pressure on the soft tissue, you can create a necrosis. So now we have at 5 weeks maturation, and this is how the soft tissue has healed over that implant. Keep in mind, I have a healing abutment in here, and you can see where that implant is exiting. So it was not an easy thing to deal with. And sure enough, we ended up creating an exit access to the implant. We put an abutment that is modified, and this is where we had achieved at the end. You can see the before and after laying out next to each other, and we ended up with a great result. So again, having another tool in your armamentarium can be also helpful, because definitely people will argue here, should we remove that implant completely? Or should we do a connective tissue graft, or should we do what we did? And I think a roll technique is a technique that it can be very helpful. I've done it on multiple occasions, but I urge you to follow my protocol, no vertical incision, because that can create a necrosis point at that level. I'm not saying it's easy, but it is very feasible. So that leads me to this case, and here this is a patient that was referred to me from another patient. That's one of the best things that happened. And here it was treated by a local oral surgeon, and they placed the implant too close to each other and with a periodontally diseased teeth. That created, as you can imagine, a problem by having the implant too close to each other. Now you have a bone lost between those implants, and then after that you have exposed those implant surfaces to the element of periodontal disease that exploded to a higher level. Now, sure enough, the thing is to remove them. But I started by treating the periodontal disease. We removed that tooth, then followed by a removal of those crowns and removal of those 2 implants. And you can see so many problems went into that implant, not only the placement. Look also the way it was positioned. They were not positioned by the manufacturer specification, And you can see here the thinning of the metal of that implant. Nevertheless, we removed them. And once we started treating the case, you can see here we had a lingual deficiency on that implant. Now, this is how I deal with these cases. Last week, I showed you with a titanium mesh. Now, it doesn't mean that every time I do titanium mesh. Here, I resorted to the Straumann Flex membrane. Again, I cannot emphasize how much I love those membranes. I have tacked the membrane on the lingual. I have tacked the membrane on the buccal. So what I created is I created two curtains. Now I start layering the bone on both sides, as you can see. So I start with the cancellous, a mixture of both, and then on top of it, a cortical bone. Now, in hindsight, I can say that this tack here was too limiting. Probably I should have moved it to here. But nevertheless, sometimes we do these things. And now I fold the membrane on top of each other. So one goes down, the second one goes up on top of it. Now, this is what I want. I touched on it last time. And I despise the terminology sausage. The sausage is something, I don't know what this fantasy about it, because the sausage is a round shape. We don't have round shapes. We don't want a round shape, because if we create a round shape, this is where you're going to put that implant. This is where they become the thinnest amount of bone. So that's why I defy that principle of calling it sausages. And on the opposite, I want to create something that I call rectangular, or at least square. And the reason I do that, because I want to create as much thickness between the border of the implant and the bone that is here. So that's why you have to be careful what you hear out there in these on these podiums. And secondly, I don't dissect the flap. I don't do vertical incisions, as you see. And again, I stretch the tissue. Look at the tissue, how much it stresses. Now, if you want, and you have fibrotic tissue inside, you can remove it. Now, I was asked this question, are you afraid from this elastic fiber that it pulls back? Not at all. And that's what I defined in my flap. We talked about the suturing. The suturing is the most important. So you passivated the tissue. I don't cut into the flap to mobilize it. On the opposite, if I cut into the flap, this is when the tissue retracts. But if I mobilized it intact, the flap is not going to retract. It will retract because that's how it is. And Dr. Wickedjoe talked about that. But you minimize the amounts of contraction because you didn't create an injury. And secondly, the most important, that's what I touched on it last time, is the paper by Hyatt back in the 60s. And they talked about the suturing. Suturing is very important. I can see I am not stingy about sutures, and I start doing horizontal matrices, as you can notice, and then I add on them interrupted sutures, and you can see here horizontal, 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 just because I don't like to create a scarring tissue with the interrupted into the mucosa. Then we go ahead, we wait for the bone to heal, and then we take a scan. We're interposing it with the intraocular scan, and you can see now the positioning. And now we place it accordingly to the plan. And definitely, we still need to do crestal sinus elevation. So we are creating the width, we're creating a little bit of height, but we're not going to get away from avoiding a crestal sinus elevation. And that's, again, what I did. So I created the base, and from there, I can build upon it based on a very strict protocol of placing the implant prosthetically driven. So I set my goal, and then I place my implants. So again, this is how it is for each implant. I'm walking you through the 3 of them. And you can see the amount of bone that we have achieved. And we did the guidelines as we talked before. And now we go back to the flap. This is how I do my flap. This is what I call the U-shaped flap. U-shaped flap. So again, I have mobilized everything. So I cut exactly 20 millimeters of the keratinized tissue. I move it out. Before, we used to do the H. And the problem, if you do the H, now, if you want to suture the lingual, the buccal to the lingual, you have to transport that buccal forward. And that's what I wanted to avoid. So I have to place the implant following the Straumann protocol of 1 millimeter subcrestal, following the IPI positioning of the depth. And now I sutured it. I didn't do a one stage in here, but again, I repositioned the same. And this is the follow-up because I did crestal sinus, so I wanted to let the bone heal. And now, 5 months later, we come for the second stage. And this is, again, you can show you the discrepancies and how you can manage them. And this is how I managed the flap. I went back and I did the U-shape. Now, what you see here, This is what I do, the pseudopapilla that I create. So I have an excess of tissue because my incision is literally lingual to that exit hole or the platform. And then I have an excess tissue here. So I have to leave that excess tissue that will create a pseudo pocket for me in the long run. So again, I do this incision, I rotate my papilla, and I position them between the implants. And this is the soft tissue healing. You can see it matures nicely. And this is again the beautiful work of Dr. Farhani with Giacomo. And they did this temporary, they let the soft tissue heal, and then this follow-up of radiographs. And then sure enough, they moved from that to the permanent, and they placed it, and you can see it nicely done. It espoused, and look at the beauty of the soft tissue with the pink. So moving along from that, I want to address the subject that we all hate, which is the peri-implantitis in the last 24 minutes that we have. So peri-implantitis, this is now it is in the diagnosis. This is something not anymore, it happens with me, it doesn't happen with me. This is something that is relevant, it exists. We have documented it, and it is now in the diagnosis. There's two parts. There's the peri-implantitis and the peri-implant mucositis. So when we look at that, let's go back to the definitions. And those are, again, a rubric that came back from the 6 European consensus of workshop, because this new diagnosis took place with a collaboration between the American Academy of Periodontology and the European Federation. This is the first time we had this beautiful minds sitting together and coming up with a beautiful diagnosis. For some, it is they are reluctant on it. I think if they read it well with an open mind, they will espouse it very nicely, because there is statements that makes a lot of sense, especially on peri-implantitis, where they correlated the amount of risk, the risk of periodontitis that leads to peri-implantitis. So for instance, you have a patient that have a periodontitis. So if you don't diagnose them and you treat them properly and you go ahead and place an implant, you're going to have a higher risk of peri-implantitis on those implants. And this brings me to something that was very dear to my heart, because when I was young and I was at the beginning of my career, we had a big tenor at NYU, and he used to, I invited him once. I used to run the third-year dental student seminar, and I invited him here and talking about perio, and he tells those young fellows that, they are not even a dentist at that point, extract the tooth, put an implant, look how the bone grows. But now we know that peri-implantitis is a high risk when you have a periodontitis. And that's why I want to emphasize on this point right now, because that's something that bothered me all along my career. So we talked about the mucositis, which is inflammation that's limited only to soft tissue. Now, when we talk about peri-implantitis, this is when it goes down to the bone. Now, there is a huge debate, and still will always be, about the effect of probing and the bleeding upon probing around the implant. I am somebody that don't believe in probing around implants, and I am adamant about it, because what are we probing? And if we give a lecture on peri-implantitis, I can talk to you in length about it. But we are dentists, we love numbers, and that's why we want the probing. But the probing is inaccurate. The most important is learn how to read the soft tissue and see the changes that happens in the bone. And that's what is so important. Look at the soft tissue, it's inflamed, nobody can question it. Look at the bone, it's osteorized. That's why once you put the crown, you have to create an X-ray at baseline and follow up the case over time. And this is why it is so important to do all of these things. So if we look at Schwartz publication in that peri-implantitis, he defined it in substantial and limited evidences. So let's walk with them. Now let's talk about the submucosal cementing. Well, this is something that started with me from the beginning of time. This is a young fellow that came from California. He started with early 2001. They started this National Security Agency, and he was working with them, and he came to New York. He had this inflammation, and the dentist sent them to me, and look at it. This is the first time I've seen cement. I'm talking about early 2002, late 2001, after 9/11. And now this has became my journey. Look at this. This is what I call the ring of love. That is the bonded cement. I don't know why they use it, but it's very common with implants. It's said but you can see it now. It seeps around, it creates a ring around this implant, and it blows up with this infection. Or this one. Now, when you look at it, you barely can see, but you can see something here. But this implant is gone. Now, when we look at it, this implant is bathing with cement, not a little bit, bathing with cement. And look at it. Look at this is where it is. This is the connection. Look where it projected, like a projectile, it's been sent down. So you can see this is the problem with cementation. And this is another case. This is a sinus. This is courtesy of my associate who was my former resident, Dr. Andrawes. He works with me now. I'm very proud of him. And you can see this is in his sinus. That implant was placed, again, was grafted with xenograft. And when you put peri-implantitis, it explodes tremendously. You can see this is look at the abutment is bleeding, it's painted with cement. This is another one. Now when you look at it, it's screw retained. But sure enough, we opened it. This is also courtesy of Dr. Cecilia White, who graduated from the program last summer. She practices in New Jersey, another very nice star that we have. And look at it. So how come? This is a screw retained, but yet we have cement. That was the new era that they started cement to screw, something like that. Again, this is what I want you to be aware of. This is also from Thomas Kalesh, a resident of mine who is now in Austria. Again, look at this, screw retained, but yet you have cement. Again, these are the things. We are creating a lot of problems that we can avoid. Now let's move on with the iatrogenic, and we look at also the cantilevers on the implant, the buccal cantilever. If you have an emergence angle of over 30 degrees, you are going to create a risk of peri-implantitis. And sure enough, let me show you those two cases. This one, she came to me, she picked me up from the internet because she saw some publication of peri-implantitis, and you can see this one. This is an overhang. Or this one, the same thing. Again, when you open it, you can see the amount of loss of bone. So, history of periodontitis. A patient with periodontitis, look what happens. This is a young lady at 37 years old when she presented to me. She had them in early 20s. Now look at the location. These are the centrals. Look at the amount of destruction of the centrals. Look at the molars. That's what you used to call the juvenile periodontitis. Those patients, once you have periodontal disease, which is called later on aggressive, now we call them stage 4 basically, or sorry, stage 3, depending on the moment and in size of a location. And again, this one what I call a human mutilation. A periodontal disease, when unchecked, led to peri-implantitis, and the implants get exfoliated, but the problem is they took all the bone with them. When you look at the scan, this is really a drastic image. And if we look at the pathogen, you can see, look at, she has the Prevotella, the Porphyromonas gingivalis, the AA, pretty high, everything. She scored on every red complex that we can have. Again, periodontal disease, I cannot emphasize how important it is to diagnose properly the periodontal disease. So let's move on with my last part, which is the management of peri-implantitis. There's a lot of paper talked about, this is a systematic review, literature review, but Subramani talked about mechanical and chemical, and even they said that the photodynamic therapy have shown minor beneficial results. Some people love talking about lasers. And again, I understand that this is something, this is their passion, but is it real? Again, Valero, same thing, talked about the importance is the removal of the biofilm. And just this month, we had finally our publication came out. And this publication is very important because it took us over 5 years to get it finished and published. And I want to thank the crew of people that they worked with me. These are Mohammed is in Kuwait now, and he was in his master's and then joined us in Perio. Kifaya is from Libya, and Abdullah is also from Kuwait. He's doing Perio in Boston, and she just finished her DDS. And we have Stephanie, who graduated from the program, and she's practicing. And definitely Dr. Ritchie, a very famous biomaterial legend that we have at NYU. But what we found is that, importantly, is that implantoplasty showed the complete disturbance and removal of bacterial biofilm by comparing everything from the brushes to the air abrasion to laser to hydrogen peroxide, acid, everything you can imagine we tried at that time. Now definitely there's newer product that came out, but nevertheless, implantoplasty has shown the best. So let me walk you through 3 cases and we finish the webinar. This is a case that she presented. This is an implant that I placed myself after 5 years. This is somehow about the 5 years. We always see these problems. You can see the inflammation, the color of the tissue has changed. You take a X-ray, you can see this saucerization of the bone on one side of that implant. Sure enough, when you open, I treat them exactly. I'm going to show you, and this is what I did from 1997. So I do removal, degranulation of the soft tissue, and then I treat the surface of the implant. I use a fine carbide nowadays, and you're going to see it in the video. I remove, I polish the surface. I put an acid etch at first for 1 minute, the same acid etch, 37% I use for bonding. I rinse it out, I put it for 1 minute, I rinse it out, and then I look at whatever there is this dark spots that happens on the implant. I have no explanation to them. And then I take a very fine carbide and a fine diamond white ring, and then I pass them along to remove the surface. Then I start using the regular perio. I do cancellous here. I don't do cortical bone, and I put the membranes, and then I achieve primary closure by mobilizing the flap coronally. This is a 5.5 years. Now, I like to show her case. She passed away. She was one of my first patients in the practice, so I have a very fine, fond memory of her, and that's why I show her case. But it was success, 5.5 years. And if you look at it on the radiograph, you can see the amount of bone regeneration. Now, definitely difficult to say we have re-osseointegration or not, because unless you do histology, but the studies are showing that if you do a good debridement, you will end up with some sort of re-osseointegration. And look at this case. This is a young fellow that presented. He had an implant in position number 8. And when you look at it clinically, you can see there was a history of apical. Already we have a compromised flap because it's fibrotic. And secondly, you can see this white cloud, which is the xenograft. You can imagine immediately when you look at the scan, this is what he did. The guy who did the implants follow exactly what he's been told. You know, they told him about this classification of sockets of type 1, type 2, type 3. Put the implant, put the bone, and the water from St. Peter is going to come and the bone is going to grow. No, in reality, it doesn't. And that's why I written a new classification, and that's why I hope that you all look for it. And if you want it, I'm more than happy to send it to you. But this is a xenograft, and then you put peri-implantitis around it, it will explode because the bone that grew on it, what I showed you in the histology last time, it goes away and you end up with the ceramic inside. So sure enough, when you open, this is what you start seeing. I do use the laser. I use the laser to degranulate the soft tissue, the granulomatous tissue, and then I clean up also with it. But this is, look, this is the cement. Never fails, always repeat itself. So let me walk you with a video about using the laser. And you can see I'm passing the laser and that cement is not going away. Now I go again and I take my fine carbide, and just to show you, in 2 seconds, it's gone. So what I do is I use a fine carbide white band, and I use also the diamond white band. I put acid etch, I rinse it after 1 minute, and then I start putting my bone. Now in reverse should be, I start with the, definitely with the laser to do granulomatous tissue. I put the acid etch, and then I clean it, and then I go with the carbide burrs, and then, but here I had that cement that I wanted to remove. I start with cancellous bone all around. I don't remove the crowns, and I don't sink the flap, the implant. And then on top of it, I put another cortical if I have to, and then I put my flex membranes, which I make them 2-layered. One is a U shape that goes around the neck of the implant, one on top of it. And then I hide the tissue coronally with the slicing. And this is, again, this is a follow-up of 4 years. This case has been stable like that over the time. And finally, this is a case was referred to me with one of my resident, her mother, and for a root coverage on number 6. But last thing she told me that there was an implant. That was to show you that you should bring the patient first and get to know them. And that was the day of the surgery. Now, when we look at it, you can see there was a fistula here. And then I started, opened the flap, cleaned that up. There was an excess of gutta percha that I debrided. I placed some cancellous, and I went for the soft tissue, and I brought it, and I mobilized the flap, and that is the final result over 2 years. And I haven't seen her, but she's very well maintained. I'm sure that her daughter is doing a great job for her. So I want to end exactly on time, what I call it the shamanisms. There is 3 things that I am adamant about them. And this is biology always win. Secondly, fundamentals never change. And thirdly, set your goal and walk your way back. So with this, I want to really thank Stroman for inviting me, and I hope that you found those 3 webinars instructive. If you want to be in touch with me, these are all my contacts. This is my email. You can also follow me on Instagram or Twitter or LinkedIn or Facebook.